Next up, we are going to hear from our keynote speaker, Dr. Amy Bohnert. Dr. Bohnert is a public health researcher who serves as the opioid content lead here at the University of Michigan Injury Prevention Center. She's also an associate professor in the Department of Anesthesiology at Michigan Medicine and a VA health services researcher. Her research focuses on prescription drug overdose, pain, addiction, and mental health, and uses a combination of pharmacoepidemiology and scalable technology-aided interventions. She served as a scientific advisory role to the CDC, including a member of the expert panel for the CDC's guidelines on prescribing opioids for chronic pain. As a reminder, Dr. Bohnert's talk will be taped. However, she will join us for a live Q&A following the talk, and please put any questions that you have for her in the Q&A function that's attached to the website. And please join me in welcoming Dr. Bohnert for her talk.
Hi, thanks for having me here. It's such an honor to be presenting at the University of Michigan Injury Center Research Symposium. The center has been such a critical part to my own research development over the last 10 years here at U of M, and is such an important part to contributing to the intellectual growth of many injury researchers. I'm going to talk about suicide and unintentional overdose, which are two injury topics that have been particularly important in the last 10 years in the US to study. I'm going to talk about some shared causes between the two, and then I'll talk about some potential shared solutions that take advantage of the fact that there are similarities between suicide and overdose towards being able to prevent both at the same time. I'm Amy Bohnert. I'm a public health researcher by training, and I'm an associate professor in the departments of anesthesiology and psychiatry at U of M. I'm also a researcher with the VA Center for Clinical Management Research. I want to acknowledge that some of the work I'll be talking about today and other work that I have that I won't be talking about is funded through a variety of sources, but in particular, some of this work was supported by the VA Central Office. So for that one, it's important to note that these are my opinions and not necessarily those of VA leadership. I'll also talk about work funded by the CDC, by SAMHSA, and by NIDA. I also have many, many colleagues who've had a huge influence on my thinking in these topics, but especially want to thank Mark Ilgen and Mark Lorschel. This is where I wanted to start with talking about why overdose and suicide are exceptional among other health problems that the US is grappling with today. There's a number of different reasons, but I think an important one is the fact that they are both increasing while many other causes of death are actually decreasing. So these are index death rates, meaning that it's comparing each year to the baseline year in 2006. And you can see that unintentional overdose and suicide stand out as both having increased substantially over this time, while many of the other common causes of death, especially cancer and heart disease, where improvements in medical care have resulted in actually some noticeable decreases in mortality over time. All of our efforts, all of the funding that's gone towards trying to address these problems, we still unfortunately see very large increases. I wrote some about the phenomenon of how these two are linked together with my colleague Mark Ilgen for a narrative review that we published last year. You can see collectively together, suicide and unintentional overdose have a mortality rate of 33.7 deaths per 100,000. For context, that is actually meaningfully more than the number of deaths related to diabetes each year in the United States. But what's more is that I think that these deaths are probably actually underreported. There's a lot of stigma around mental health and a lot of stigma around substance use, and they are complicated to determine what was the cause of death afterwards, and I'll talk about that a little bit more later. But so you can see while there's, these are the trends again for suicide and unintentional overdose. I have a paper in press with the American Journal of Public Health now that'll be coming out next month, where we found that there were a substantial number of deaths coded with psychiatric and behavioral diagnoses that don't actually describe a mechanism of death. So these are not included in any of the surveillance related to overdose and suicide, but very likely are misclassified suicide and overdose deaths because they're coded with diagnoses like major depression, which may very well be a suicide death. They're coded with things like alcohol dependence, but not in a way that makes it clear that it's actually the results of long-term alcohol use. So as a little bit of an outline, I'll start with talking about some shared causes. Those will be both at a societal level. So what are the societal forces that may be underlying why these are increasing? I'll talk about the intent issue in a little bit more detail, and then I'll talk about individual level risk. So if you're looking at an individual and a health system in particular, what might be the factors that put someone at higher risk for suicide and higher risk for overdose, and how do those overlap? And then I'll talk about that issue of the shared potential solutions that take advantage of these similarities. One of the societal level causes has been supply. So, there's the concept of supply versus demand. And on the supply end, it's very clear that opiate prescribing in particular, so not necessarily illegal opiate access, although that's changed more in recent years, but opiate prescribing went up dramatically. And parallel to those increases, there were increases in opiate-related deaths, and specifically opiate-related deaths due to prescription opiates. I think, it certainly is not the case that this is the only issue, but in any substance that we've looked at over historical time, it's always been the case that when more is available, there's more harms related to use. That's true of alcohol, certainly true of tobacco, and not surprisingly also true of opiates. Oftentimes that's talked about, so as I mentioned, supply versus demand as a contrast of, is it that there's more or is it that people want it more? The framing of the demand has often been through the idea of deaths of despair, if people have heard of that. So the idea that there's much less economic opportunity, and that depression, economic depression, results in people needing more ways to cope, having less hope for the future, and as a result, using opiates more. This has come from some ecological data that has shown that the overdose-related deaths have particularly increased in areas that have been harder hit economically within the US. And I think there's certainly some reason to think that that was a factor that contributed towards the increase in overdose deaths and contributes to suicide deaths. I think it's important to note that it's not as simple as just addressing the economic factors at this point. For both the supply and for the deaths of despair hypotheses. Unfortunately, once there's a lot of exposure with the way that opiates are a reinforcing drug, just taking them away suddenly, just taking away the economic conditions suddenly, is unlikely to change the way in which there's a number of people who now have substance use disorders, have opiate use disorders, need treatment for those disorders. And it's also important to note around the economic factors that countries that have an increase in wealth often have an increase in substance use that goes along with it. So again, complex situations, complex causal relationships at a country level, and there are unfortunately no simple solutions at this higher ecologic level. So those were some of the societal level drivers of causes that might be increasing both intentional overdose and suicide. But there's actually a much more simple way in which these two are linked. And that's that when there is a death that is an overdose death in particular, it can be difficult to determine whether it is intentional or a suicide death versus what we call unintentional. One of the clear ways that makes it easy in the case of death investigation is whether if there's a note, certainly if there's a suicide note that pushes the evidence towards it being a suicide pretty strongly. However, it's a fairly small proportion of all overdose deaths in which the evidence is all that clear. An issue is that it's many jurisdictions don't have a ton of funds that go towards death investigations. So actually, there's a lot of missing toxicology data. States with the centralized medical examiner system don't have this problem nearly as much. But unfortunately, that makes it difficult to, in particular, report what substances were involved. And there's some degree to which knowing that can help inform the intent. Another issue, and I intentionally use a picture from one of the Baltimore-based shows for this, is because they're a particularly unique example of it, is the resource allocation. So In Baltimore in particular, much less effort is put towards investigating whether a death is by suicide or unintentional overdose, because they need to spend much more of those resources towards focusing on homicide deaths. So, so many ways in which I think we underappreciate the resource constraints that affect the classification of death, and that has a fairly big impact on our ability to conduct high quality surveillance in this area. But related to the issue of intent, the way I just described it comes from, and the way it's reported and thought about in a surveillance way, comes from the idea as if it's clear that some deaths are suicide and some deaths are unintentional overdose, and there is no gray area in between. I would posit that actually intent is not binary. And this comes from a couple different survey-based studies that we've done and that other groups have done as well. So for emergency room patients who had a prior non-fatal overdose, about a quarter said that their that their prior non-fatal overdose was a suicide attempt, but another 21% reported that they weren't sure whether or not it was. In an addiction treatment sample, a former PhD student here from U of M, Rachel Guiquile, looked at a survey we did with a couple hundred folks in addiction treatment. There, not surprisingly, a much smaller percent reported that it was a suicide attempt, only 7%, but another 44% said that they didn't care about the risks, or other statements like that that suggested that it would be certainly not classified as a suicide attempt, but they certainly were also aware that there was some risk that they would have an overdose, and they took risks that regardless. In a study that I was not involved in with patients hospitalized for opioid use disorder who had a non-fatal overdose, a third reported a level of 7 or more on a 0 to 10 scale of suicidal intent. And part of what was really interesting about that study was that people were clearly comfortable with and willing to report the intent of their overdose on a continuous scale like that it made sense to people to think about it that way. So that third shared causes topic I wanted to talk about was individual level risk. And the especially important drivers of this, and this is true both in health systems, but also at a population level, is pain and especially opiate prescribing history. This is data from a pair of studies that a group of VA researchers I work with did. I led one that was on the unintentional overdose death, and my colleague Mark Ilgen led a paper on suicide death. For both of these studies, when you take a cohort of people who are prescribed opiates, the higher the opiate dose you received, the greater likelihood you had of dying by either suicide and unintentional overdose. You can see that the effect size of that relationship is much larger for unintentional overdose than for suicide, but nonetheless, it's interesting to see that the pattern goes in a similar direction, that those two track together rather than being in contrast with one another. And part of why I say that it's interesting and potentially surprising that they go in the same direction is that sometimes we think of this as a trade-off between the two. That if you treat pain more aggressively, you might reduce someone's risk of suicide, but increase their risk of overdose. But in fact, that was not true, that treating pain more aggressively, at least with opiates, also appears to be associated in the same direction of increasing their risk of suicide. I'm going to talk a little bit more about a paper where we talked about this looked at this even more directly by looking at overdose deaths by the intent. So this was again the VA, which has been a unique opportunity for studying these problems because it has a national link of National Death Index data, which is the gold standard for cause-specific death, with all the caveats that I alluded to earlier, but linked to medical records. So we know someone's all of their prescribing history, at least in terms of their VA prescribed medications. And here we were able to compare. So I think this is the unadjusted, and I think an important thing to just say off the bat is that all of the substance use disorders and psychiatric disorders that we looked at were associated in a positive direction with all three outcomes. So with unintentional overdose, suicide overdose, and undetermined intent overdose. So again, here's definitely a shared cause across the three, but then we looked at it in comparison and adjusting for other factors. So this was from a multinomial regression, where the point was to look at how the risk compares with one relative to another. So, so for example, to take this first one here, this would be the effect of of a drug use disorder. What is the effect size of having a drug use disorder compared to not having a drug use disorder, looking at unintentional overdose relative to intentional overdose? So meaning that having a drug use disorder has about twice as strong of an association with an unintentional overdose as it does with a suicide overdose. And that was similar for these undetermined intent. So for the substance use disorders, the risk is a little bit higher for unintentional or undetermined than it is for suicide-related overdose. But for other psychiatric disorders, and I dove in here with depression and PTSD as specific examples, but these were characteristic of all the others that we looked at. The effect was about the same, if not a little bit stronger for suicide than overdose. But nonetheless, we think of suicide as being very clearly mental health related and unintentional overdose as being less so. And I think what this showed is that they actually are much more similar in terms of the psychiatric history of people before they died by an intentional or an unintentional overdose than has been traditionally thought of and as it's been addressed in terms of prevention efforts. So as I said, psychiatric and behavioral conditions are common across overdose death types. That group with the deaths that are called undetermined intent, so the medical examiner wasn't able to say whether it was suicide or intentional overdose, those have a particularly complex psychiatric history, which may reflect that it's difficult to determine if someone has both substance use and a lot of, say, psychiatric treatment. It may be particularly difficult to determine what were the events preceding that overdose. And again, I think intent may not be best described using those discrete categories, which I realize makes for a complicated way of doing surveillance, but nonetheless better reflects the reality. Just in terms of big picture, I think I want to put out a potential causal model of how these things relate to one another and reflect that this means that it's very complicated to get at these relationships, especially given that we mostly are stuck with looking at observational data to look at these very complex dynamics. So it's very well established that pain increases depression. It's also clear that pain increases opioid use. Both of those factors in turn increase suicide risk and increase overdose risk. So when we're trying to talk about, say, the effect of pain on suicide risk, or the effect of, say, opioid use on suicide risk, adjusting for pain, that can potentially create modeling problems where you're adjusting for factors that are on the causal pathway that essentially end up answering not the question you're trying to answer. So it's important to think about how all of these things are tied to one another. I think I intentionally want to say here that pain is in many ways a fundamental aspect of this, that the opioid use is often the most proximal problem, but if we're not treating pain better and addressing pain better, it won't eliminate suicide risk to just eliminate opiate risk. Improving treatment of pain in particular is really important. I want to use the last couple of minutes to talk about shared prevention approaches, and I'm not going to talk about all of the things that are here in this table. This is from the review paper with Mark Ilgen, but I wanted to highlight a couple that I think are a little less well known, and this is in the paper that came out last year in the New England Journal of Medicine with more description of the details of what some of these interventions look like. So one thing I want to talk about more is counseling approaches. So these are both studies around how cognitive behavioral therapy has been effective for reducing suicide risk in patient groups that are at risk for suicide. I think that's been, I think that's, not entirely unexpected, that we do think that mental health conditions are responsive to counseling, and suicide we think of as a mental health outcome risk. But nonetheless, I think sometimes we think of suicide as being a more intractable problem and a more difficult to address problem, and don't necessarily appreciate the degree to which making specific counseling approaches, this is CBT for suicide risk, more available might have a big impact on reducing suicide. This is building on less robust data, but nonetheless, we did a study funded through the Injury Center, and this was published in 2016, where we recruited patients while they were waiting for care in the emergency department, and we gave them either a motivational enhancement-based intervention for reducing overdose risk behavior or some educational pamphlets on overdose risk. We found that at 6 months later after the emergency department visit, the folks who were randomized to the intervention condition had substantially greater reductions. So the y-axis here is percent reduction in symptoms. They had substantially greater reductions in overdose risk behavior and actually opioid misuse as well, using the current opioid misuse measure compared to those people who were in the control. So again, while we might think of overdose risk as something that is a particularly intractable problem, that people are going to use substances in risky ways if that's what that they want to do. In fact, there's a lot of opportunity for not just education about what's risky, but also increasing people's motivation to protect themselves. I want to talk about another really incredibly important tool that we have for reducing overdose and suicide risk, and that's medications for opioid use disorders. So this was a particularly good study, strong study that came out about 2 years ago, where they tracked patients who were treated for an opioid overdose and found that unfortunately only about 3 in 10 received the treatment, medication for an opioid use disorder. So there's a huge amount of unmet need here, but among those who receive it, the risk of death goes down by about half compared to not receiving that if they receive methadone or buprenorphine, which is a pretty dramatic effect on reducing death. I think most treatments, if they reduced your risk of death by half, we would consider that a miracle cure. And unfortunately, nonetheless, there's a lot of stigma around use of these medications, and in many different ways, there's not enough access, there's not enough providers who prescribe it, which relates to some recent work I want to talk about that we're doing here at the University of Michigan. So I get to co-lead this program called the Michigan Opiate Collaborative with my colleague, Allison Lin. We work all throughout the state of Michigan, providing supports to both physicians and communities to try and increase access to medications for opioid use disorders. What that means in practical terms is we help physicians get through the waiver training if they need it. We provide technical assistance on things like how to set up your clinic for doing, say, your toxicology screens, and then same-day consultations. If they call, they get a call back from an addiction specialist to answer questions about a specific patient. We also have behavioral health consultants who are located within a given county, who help build community connections. They help being a not just same day, but same moment support to those physicians and their offices. They do outreach to offices to try and find folks who maybe are on the fence about whether or not they want to offer this treatment, but would need more support, and help organize webinars and other trainings and other types of meetings. So this is our website, michiganopiatecollaborative.org. Very happy to do anything we can to support anyone, but I think this has been a nice way to translate what I have seen in the data towards a program where we can try and do what we can to address these issues with the things we already know that work, but are not nearly available enough. So some final thoughts. I wanted to throw some ideas out there for anyone who might be looking for things to study in this area, of things that I think are Emerging areas are really important unresolved controversies. The issue of it's clear that opiates for some people may be increasing their risk for suicide and overdose, but how to stop, who should stop are really unresolved questions that cause a lot of controversy around prescribing guidelines. There may be biases in cause of death classification related to race, related to gender that have not been well explored. There are many issues of stigma here, stigma around race, around who gets access to treatment for opioid use disorders. And there are new risks on the horizon. So I haven't talked much about illicitly manufactured fentanyl, but the increase in the last several years is clearly driven by this problem. The prescription opiate overdoses have been declining along with the reductions in opiate prescribing. And we've treated this in many ways from a prevention point of view as if it's a problem that will resolve itself. None of the prevention is very specifically tailored to the particular risks of the very potent fentanyl. But I think that probably needs to change. We need to have more prevention prevention approaches that address that specifically. So in summary, there are some similar pathways here involving poorly managed pain and the many problems that go along with it that drive both overdose and suicide. And by addressing those shared risk factors, we have the potential for very efficient public health approaches that are cost effective by addressing both at once. With that, I look forward to your questions. Please feel free to email me or contact me other ways.
Thank you, Dr. Bohnert, for that great talk. We'll open the live Q&A portion of our talk now, and I just remind everybody to please submit their questions through the website so that we can present the questions to Dr. Bohnert. The first question for you is, you talked a lot about how opioid use was intertwined with other mental health factors, and I think in this unique moment we have with the COVID-19 epidemic, I wonder what we know about how opioid use has changed or opioid overdose deaths have changed, especially when this pandemic is raging.
That's a great question, because clearly the pandemic, both in terms of people experiencing COVID and also the difficulties associated with social distancing and all the necessary, steps for decreasing transmission, have a pretty substantial effect on mental health. I think at this point, there's some preliminary reports suggesting that overdose deaths have gone up in this period. Actually, a little preliminary data suggesting possibly that suicide deaths have gone down. A challenge with all of this, all of the work in this area is that the mortality data, to get good national numbers, there's a clear lag in going from a death occurring to the autopsy and medical examination to the state vital statistics to CDC, where that data gets clean before it can be reported. So unfortunately, we probably won't know for sure until another maybe 6 months to know really what's happened.
I think that's really important to keep in mind. And I know we have seen some data from our SOS system that Dr. Goldstick talked about earlier. And I think as we get a little bit further distance from this moment in time, we'll have a more clear picture as to what's going on.
Yeah.
Those are really important points.
Yeah, SOS is a great early signal for what's happening. And then the deaths take much longer, unfortunately. Well, yeah.
Yeah. Absolutely. I wonder, another question that's come in is, sort of what the public health implications are of the research that you're doing currently.
Of current research?
Yeah.
So I think public health implications, I would say there's a lot of research going on, so it's hard to pick one to talk about. Is there a specific piece of it that would be?
So I'm curious about some of the intervention work that you've done. You've done some work through the center and you have some ongoing projects in that area. I wonder about sort of where you think that goes in the future, or what the public health implications of that for practitioners or for clinical space are in that realm.
Yeah. So I'm really interested in, as a number of other folks at the Injury Center who are really strong in this kind of work, doing technology-aided interventions that have the potential to stretch the limited number of behavioral workforce individual people we have, and number of trained counselors, to reach as many people as possible. So I don't think that we necessarily can go to systems of mental health care that are absent any social workers, absent any care providers, entirely relying on mobile health. But we're using reinforcement learning approaches to figure out who needs that in-person care when, and how you can give, essentially completely mobile health delivered boosters to help people through when that's enough. So I'm really interested in how to take a small amount of resources and use technology, use innovative things that our colleagues in engineering are coming up with to maximize the impact as much as we can.
Really important to not take the human element out of the people who need it the most, but also for whom can we deliver something that is maybe less intensive or has technology to aid it and would be more cost effective. Mm-hmm. Yeah, I think that's really important work. Well, I really appreciate your talk and talking with our center today and all the work you do with the center. And I think it's really, really important. So thank you.
Yeah, thanks for having me.